Hi, good evening, everyone. So, this week we are going to continue our lectures on venereology and we'll be continuing our discussion on genital ulcer diseases. Last week we had discussed chancroid, genital ulcer disease caused by Haemophilus ducrei. This week we'll be discussing Donovanosis. Now, the point of discussing ulcer diseases together is to find out some subtle differences in between amongst them, okay, so that you are able to clinically distinguish what kind of ulcer you're dealing with. Of course, with NACO we have the syndromic management. You treat it as a syndrome of genital ulcer, but we as dermatologists and venereologists would require we have to go a few steps ahead and try to distinguish the causes of the ulcer and not treat it syndromically as such. Plus, a few points about Donovanosis is that it's a rare disease. Rare disease in that sense that it has become rarer now. Okay. Prior to the HIV epidemic, which started in the year 1983, the ulcer caused by Donovanosis was actually very, very common. It was one of the most debilitating and common disorders of the genitalia prior to the HIV epidemic. And because of the advent of newer antibiotics and proper public education and guidance, we were able to control this public health disease. Now, remember that there are certain pockets left in the world in which you find the endemic centers of Donovanosis. And we need to know that because any kind of travel from these areas, you might have the reoccurrence of this disease in your patients. Any patient traveling from these endemic pockets might develop an ulcer disease. And with the rise in the not rise per se, but the rise in the public education about the different STIs and people coming forward for their treatment, the disease is now not making a resurgence per se, but we need to be much careful about handling different kind of causes of genital ulcers. So with that in mind, this week we'll start our discussion, or rather a lecture on Donovanosis. Without much further ado, let's move forward. Now, the causative organism is Klebsiella granulomatis, and this is the new name. The older name is Calamantobacterium granulomatis, and this is an older name. Now, the word calimato comes from either cloaked or hooded, okay? And that is because the lesion, the ulcer, it has somewhat of an undermined margin, the same that we saw in chancroid last week. And because of that, it looks more of an hooded ulcer, so it was named as Calamantobacterium granulomatis. But subsequently, with different phylogenetic studies, and when we looked at the genetic material of the organism, it was clinically and also phylogenetically, phenotypically, genotypically, it was closer to the Klebsiella genera. And because of this close proximity to the Klebsiella genus, the name was changed from Calamantobacterium granulomatis to Klebsiella granulomatis, and that is now the newer name. So if we remove everything so that everything becomes a bit clearer, so it is Donovanosis is a genital ulcer disease caused by the organism Klebsiella granulomatis. So remember this new name. Now, apart from this new name of the organism, the disease itself is known by a variety of names. There are so many names. You can see this on the slide. There are at least 12 different names and maybe more than that. But some names are very common. For example, Granuloma inguinale, Granuloma venereum, not to be confused with lymphogranuloma venereum, which is a different disease altogether. That's LGV. Okay, so we will not be confusing ourselves with LGV. Simple granuloma venereum is Donovanosis. Lymphogranuloma inguinale. Now remember that you have another disease by the name of lymphogranuloma venereum, not to be confused with that. That's a different disease. Another name for Donovanosis is lymphogranuloma inguinale. Okay, the granuloma donovani, as per the name of the organism and the disease, infective granuloma. So these are all the other different names of Donovanosis, but the names which are highlighted in bold are some of the commoner names and the names that it is usually known as. And the most common other name is actually Granuloma inguinale, or a granulomatous disease of the inguinal region. So this becomes the other common name apart from Donovanosis. Let's learn a bit about the history. The organism is named after Charles Donovan, and here is that handsome gentleman, Charles Donovan. And it's a good idea to look at the picture because in multiple STI quizzes, sometimes they show you the picture and ask what is the disease named after him or who is he actually. So just look at this picture and you will understand that this is Charles Donovan. And in 1905, he was able to say that the organism is the causative agent for Donovanosis. And that's why the disease is named after Donovan. We call it as Donovanosis. The description of the ulcer and the organism was given by McLeod in 1882. The organism was isolated by Anderson in 43. In 1937, a description of Pund cells was given. Now, Pund was another name of a scientist, okay? And Pund cell was described, and Pund cells are large, okay, let me just write it down. It's large mononuclear cells, okay, and which have an intracytoplasmic inclusion bodies. Okay, intracytoplasmic inclusion bodies, and inside the bodies you have the organism. You could say a safety pin appearance, rod-shaped organism, and this organism is known as Donovan bodies. Okay, so you have a polymorphonucleosides, you have a nucleus which is pushed at the periphery, and you have multiple intracytoplasmic bodies, and each of these bodies is known as Donovan bodies, while the whole cell is known as Pund cells. And these are pathognomic for Donovanosis. You need to demonstrate Pund cells either in crushed tissue smear or in tissue biopsy to make a good diagnosis of Donovanosis. Otherwise, it might be difficult because it is a very difficult organism to grow. Klebsiella granulomatous is a difficult organism to grow. So if you want if you want a perfect diagnosis of Donovanosis, you need to demonstrate the presence of Pund cells and Donovan bodies. Okay. Now, as I said, it was a very common cause of genital ulcer disease prior to the HIV epidemic. And after the HIV epidemic and advent of newer antibiotics, the incidence significantly reduced to zero, with only few endemic pockets around the world. But there has been a resurgence with HIV, and because you know that HIV kind of predisposes for other STIs and other infections and other ulcerative diseases. And because of that, the incidence of Donovanosis is showing a bit of a resurgence with the increase in the transmission of HIV. And so much so, since Donovanosis is linked with the sexual transmission route, because of that, the presence of HIV along the same route increases the chance of developing other diseases, namely syphilis, chancroid, Donovanosis. So that is why a kind of resurgence is being seen with with increasing HIV prevalence, and we need to keep that in mind because of this. Because we need to diagnose it and treat it quickly. We will discuss the treatment subsequently, and you will realize that treatment of Donovanosis might be a bit difficult and prolonged. So we need to have some idea about when to suspect Donovanosis and diagnose it accordingly. Let's move forward. So the incidence is decreasing year by year, so much so that in multiple areas it has now become zero, okay, per 1 lakh population. But as I said, there are endemic pockets around the world, and major endemic pockets are seen in Papua New Guinea and Australia. To be more specific, Aboriginal Australia. So these pockets, which is also called as part of Oceania. So Papua New Guinea and Aboriginal Australia are the pockets. Other areas are French Guiana, which is in South America, Northeast Brazil, again in South America, Zimbabwe in Africa. So you will understand it's more of an equatorial belt. The South American countries near the equator, the countries in Africa near the equator. Along with that, you have Papua New Guinea and Australia, which are the endemic pockets, and you keep on having increased incidences of Donovanosis in these areas. In India, the textbook mentions Chennai, Odisha, Himachal Pradesh as the pockets of Donovanosis, in which you keep on getting patients with this infection. It's more common in the reproductive age group, as is seen with other STIs. The male to female ratio is described as 6:1, predominantly because of increased chances of sexual exposure in males. So that is why it's 6 times as compared to females. And additionally, the lesions are much more visible in the male genitalia. So the male patients are more likely to come to an STI clinic and take treatment for donovanosis. That's why the perceived incidence is more in males, and that is why the male to female ratio is 6:1 approximately as per the textbooks. Now remember that donovanosis is decreasing year by year. It has reached nearly zero in majority of the countries, and that is why all of this data is somewhat old. We don't have proper studies which might update this data. So just keep that in mind and accept this data with a grain of salt. Let's move forward. So this is the data which I have taken from the Australian Society, Australian data of notifiable diseases. And you can see that over the years, the incidence or the number of notification of donovanosis is decreasing from 2006 to 2009. And you can see that from 2006, it was 0.03 per 1 lakh population. It has decreased to less than zero point 0.1 in per lakh population in 2009. That's the earliest the data I could find. And so you can see with time, that the incidence, it has significantly decreased and in fact reached zero in 2011. You do have one or two occasional cases, and in fact the textbook mentions that donovanosis right now is more of a case report like nature. It's not that common anymore, but we need to study about all the ulcer diseases, and we need to keep things in mind that there are endemic pockets, and with a travel history to these kind of pockets, patient might develop donovanosis. Okay, so let's move forward. So we have discussed the epidemiology of donovanosis. We have discussed the causative organism. Let's learn more about Klebsiella granulomatis. Now, the causative organism is Klebsiella granulomatis. It is an encapsulated pleomorphic. Encapsulated means it has a capsule. Pleomorphic means that it can take multiple forms, but mostly it is present as a bipolar staining bacilli. Okay, it's a gram-negative bacilli. So keep that in mind, gram-negative bacilli, which is aerobic. It shows bipolar staining, which is a cause of safety pin appearance. So now what do we mean by that? So look at the upper right corner. So this is the bacilli. The granules inside the bacilli are stained very darkly. And because of that, it looks like a safety pin. Okay, we all know how a safety pin looks like, and that is known as a safety pin appearance. So this could be a very good Viva question. Safety pin appearance is seen in donovanosis, or rather specifically Klebsiella granulomatis. And this is seen with all sorts of stain. The most common stain which we use could be GMSA, but there are other stains also, and we'll learn about them subsequently. So it is catalase positive, phenylalanine negative, citrate positive, but these are important for microbiologists, not much for us. Okay, so let's move forward. Moving from the causative agent, which is a gram-negative bipolar staining bacilli, we will discuss the clinical features now. Okay, so incubation period ranges from 1 to 12 or 1 to 16 weeks, the average being about 50 days. But there have been reports that it might take a year to develop. That means from the point of transmission to the development of clinical symptoms, the duration can be as long as 1 year. So keep that in mind. If you're taking history or travel history or sexual exposure history, make sure you go as back as an year. Okay, now we have discussed that Papua New Guinea is one of the good hotspots for donovanosis. Other areas include India, South America, mainly Brazil and French Guiana, Caribbean, Zambia, Zimbabwe, South Africa, and Australia. So these are good areas where donovanosis is still seen, not as commonly as before, but significantly more as compared to other areas of the world. It starts, like all ulcerative disease, it starts as a firm papule, and this papule will increase in size gradually to become a subcutaneous nodule, and with time it's going to ulcerate to form the beefy red undermined ulcer of Donovanosis. Okay, now the ulcer is tender. We know that in syphilis the ulcer is non-tender. Okay, so it is non-tender in syphilis, but tender, significantly tender in Donovanosis. The ulcer is indurated. We know that in syphilis it is indurated. In chancroid, it's not. No induration. We are discussing all the genital ulcer disease together. And the ulcer is beefy red because the vascularity is significantly increased, so much so that it bleeds easily on manipulation. And this point is very important. For Donovanosis, it's a beefy red ulcer which bleeds easily on manipulation. And that is how you are going to differentiate from syphilis or the primary chancre and chancroid. So primary chancre of syphilis is a non-tender indurated ulcer. For chancroid, it's going to be a non-tender, non-indurated ulcer, while for Donovanosis, it will be tender, indurated, beefy red, easily bleeding ulcer. Okay, so that is how you clinically differentiate between different genital ulcers. Let's move forward. In 90% of the cases, you have the genitalia which is involved, while the inguinal region with similar morphology of an ulcer is seen in 10%. Extragenital areas are rare but seen in about 6% and include lips, gums, cheeks, palate, pharynx, neck, nose, and larynx, and chest. And that is mainly because of auto-inoculation from the primary ulcerative lesion. Now, lymphadenitis is uncommon. If you discuss that in context of chancroid, where lymphadenitis is seen in about 30 to 60% of cases, and with LGV, where it is nearly 100% of cases, that is also one differentiating factor between this ulcerative disease and other ulcerative diseases. Okay, in Donovanosis, the lymphadenitis is uncommon, while in chancroid it is 30 to 60%, while in LGV it is nearly 100%. Okay, so remember that lymphadenitis is uncommon in Donovanosis. The areas in males which are frequently involved are the prepuce, the coronal sulcus, frenulum, and glans. These are the areas which are mostly, trauma prone or mostly come into contact with an infective area and might develop an ulcerative lesion or Donovanosis. In women, in females, we can see this ulcer at labia minora, fourchette, and even at as inside a cervix, where it can be confused with cervical carcinoma. Now remember, development of a malignancy or a carcinoma in an ulcer which is caused by Donovanosis has been reported. Okay, and carcinoma de novo, or you could say just carcinoma of the genitalia, can also mimic Donovanosis, as in it can start as an ulcer which bleeds easily, so it can mimic Donovanosis. So carcinoma can arise in an ulcer of Donovanosis, or a carcinoma in itself can mimic an ulcer of Donovanosis. So a lesion at the cervical rim or the cervix can be easily confused with cervical carcinoma. Okay. In rarest of rare cases, it can cause what is known as disseminated Donovanosis. It is very rare, especially after the advent of newer antibiotics. We don't see it much often, and only isolated case reports are there. Even I think PubMed search usually results in about 26 entries of disseminated Donovanosis, so it's very rare. Secondary spread can occur to liver, bone, causing polyarthritis, osteomyelitis. There are individual case reports in which mastoid, behind the ear, the mastoid area has been affected. Osteomyelitis has happened because of Donovanosis. Liver abscesses, spleen, it has migrated to spleen, and that is then it becomes a disseminated Donovanosis, but it is extremely rare. It more or less it's more of an academic interest now. Now, there are four clinical variants of Donovanosis. The most common is the first one, which is ulcerogranulomatous, which is the most common type that we see, the ulcer that we see. So it's a non-tender, fleshy, exuberant. Exuberant means much more exophytic, growth-oriented. Single or multiple beefy red ulcers that bleed easily. Remember, beefy red and bleed easily. These are very important pointers towards donovanosis. And it spreads by diet extension, or it can cause multiple ulcers because of diet extension from the primary ulcer and because of auto inoculation. Okay, so you see an exuberant growth of ulcer, which is known as the most common variant, ulcerogranulomatous. In the hypertrophic or the verrucous, you could say a verrucous variety, you see a significant exophytic growth at the area. So, because of YouTube, I cannot show you the actual picture of ulcers, but in any STI book, you'll be easily able to find this kind of a verrucous growth. So, it's a growth with a raised irregular edge. The edge is irregular and it is completely dry with a walnut-like appearance. Okay. So here it is a picture of a walnut, so that is safe to show on YouTube. So you could see this kind of irregular verrucous shape, looks like a walnut has been placed over the area. It's dry, exophytic in appearance. The third variant is necrotic. It is deep, foul-smelling ulcer causing tissue destruction. The tissue destruction is significant, so much so it might require surgery for correction. And the foul-smelling ulcer, or let's say the kind of tissue destruction can be because of either secondary infection of the ulcer by Fusobacterium and other species, or by itself by donovanosis if it is the necrotic variant. The fourth is the sclerotic or the cicatricial variant, in which you have extensive fibrous and scar tissue causing significant scarring of the inguinal region. So repeat after me. There are four clinical variants of donovanosis. The first one is ulcerogranulomatous, which is the most common one. Then we have hypertrophic or verrucous. Then we have necrotic, and then we have scarring or sclerotic or cicatricial variant of donovanosis. Clear? So this becomes a very important question for, let's say, Viva. What are the variants of donovanosis? Let's move forward. Now, what are the complications of donovanosis? Now, remember that it's a bleeding ulcer. So, bleeding is one of the most common complications of active donovanosis. And after healing, if it is a cicatricial variant, it can cause significant scarring. But if we discuss the complications as a whole, we find that pseudoelephantiasis is the most common complication. Now, what is elephantiasis? It's mainly because of the lymphatic blockage causing swelling of the organ or swelling of the limb. That is elephantiasis. Okay. Pseudo, why? Because it's not the blockage of lymphatics. It's now the growth or the granulomatous growth seen in donovanosis. Its most common complication is pseudoelephantiasis, mostly seen in women in about 5% of cases more than men. Why? The reason could be because that in males, since the ulcer is located in a more visible part, they are more likely to seek treatment and get treated earlier. While in females, the lesion might be hidden, and that can lead to significant growth in the lesion before they start or even attempt to take treatment. And by the time the growth is so much so that it can cause elephantiasis, or rather pseudoelephantiasis. Okay, and this can be confused with LGV. Now we know that LGV has stages. Of course, we'll discuss that when we'll be discussing LGV. But in the final stages, you have the complications of LGV, and one of the important complications of LGV is elephantiasis and genital disfiguration. Okay, so that disfiguration can be confused with LGV. So we must keep that in mind. Urethral, vaginal, or anal stenosis can occur if it's in the sclerotic variant. Carcinoma can happen in the ulcer of donovanosis. So SCC of penis has been reported. Co-infection with other STIs, majorly by primary syphilis, both of them can happen. And if you remember that chancroid also can have primary syphilis as a co-infected STI. If it goes into an hematogenous spread or spread by blood, it can lead to disseminated donovanosis, clinically presenting as fever, malaise, anemia, night sweats, weight loss, in fact, sepsis. So in disseminated donovanosis, what happens is that the organism, the Klebsiella granulomatous, gram-negative bacilli, is now in the body system. It is not localized to genitalia anymore. It's now involving the whole body. And because of that, you have the significant systemic symptoms like fever, malaise, and anemia and night sweats. Okay, so we need to keep that in mind. And if your patient is developing these kind of symptoms, need to ask any history of genital ulcers. And we have discussed that osteomyelitis and polyarthritis can happen when the spread is to the respective areas. Remember that in disseminated donovanosis, you can have other organ involvement, which is different from the extragenital manifestation of donovanosis. Extragenital manifestation occurs due to auto-inoculation of the area, while disseminated donovanosis is because of hematogenous spread of donovanosis. Okay, you know the distinction now. If it spreads by blood, disseminated donovanosis. If it spreads by auto-inoculation, then it is more of an extragenital manifestation. Let's move forward. Now, HIV co-infection. Remember, whenever you're talking about an STI or whenever you're writing a short note on any STI, you need to discuss what happens if HIV is in the picture also. And whenever you're discussing the effect of HIV on any STI, you need to discuss it in two parts. What happens to HIV when the STI is present, and what happens to STI if HIV is present. Okay. So what does donovanosis do for HIV? Donovanosis increases the transmission of HIV, like any ulcerative disease in which the body fluid can easily exchange, especially in donovanosis, which bleeds easily. And because of the eroded mucosa, it acts as a good entry point for HIV. Okay, since the barrier, the tissue barrier or the skin barrier is lost at the site, the virus can easily infect the area. Now, what does HIV do for donovanosis? It increases the incubation period of donovanosis. So, what the ulcer was doing initially was developing in average of 50 days, but now the incubation period can be prolonged as 1 year. It can lead to multiple ulcers. It can lead to delayed healing of ulcers, and the treatment might be slow or even fail altogether if donovanosis is occurring with a background of HIV. Okay, so your primary antibiotics might fail, or you might have to combine antibiotics. You have to give two different antibiotics together for treatment of donovanosis if there's a background retropositive picture. So the treatment remains same but may require prolonged treatment or even addition of two antibiotics together. That's what CDC says. So let's move forward. Now, differentials. Whenever you're talking about differentials of an STI, you need to mention it in two columns. One is other STIs which mimic donovanosis, and the second one will be non-STI conditions mimicking donovanosis. So in STIs, donovanosis can be clinically confused with primary syphilis or secondary syphilis, specifically condyloma lata, which is the moist, exuberant syphilitic lesion, especially seen in folds. It can be confused with large hepatic ulcer and chancroid. So all genital ulcer diseases can be confused with each other. Non-STI differentials include amoebiasis, which can have a bleeding ulcer, and malignancy, specifically squamous cell carcinoma of the site or other malignancies. Okay, so donovanosis can be confused with these non-STIs. Okay, so we have discussed the clinical features of donovanosis, and now we're going to discuss the diagnosis of the infection, how to diagnose it. Now, donovanosis is a very difficult disease to diagnose in the sense that the organism doesn't grow properly. So there are other ways to diagnose. And remember, whenever you want to diagnose an infection, you need to demonstrate the organism. You need to see with your own eyes the organism which is causing the disease. So the mainstay method is actually tissue smear. Now, what exactly is tissue smear is you take a piece of tissue, you crush it between two slides, and it forms a smear. Then you stain the smear, and what do you look for? You look for Pund cells. Remember Pund cells? We have discussed that previously. We look for Pund cells which have Donovan bodies. So you need to look for that. And if you find them, then the diagnosis donovanosis is confirmed. There are few pointers that you have to keep in mind while taking the sample. Take the smear before starting any antibiotics, or the yield will be very poor. You will not be able to isolate Donovan bodies. Okay. Other thing that the books mention is to use a dry cotton swab. Okay. Moist cotton swab might actually decrease the yield. Okay. And if you have to take multiple swabs, let's say you have to take swabs for HSV culture, you have to take swabs for dark ground illumination microscopy for syphilis, then the first swab that you take will be used for Donovanosis so that the amount of sample collected is more. Okay, so you need to have a good amount of sample to increase your yield of diagnosis of Donovanosis. So if you take multiple swabs, the first swab goes for Donovanosis, other swabs may go for other different STIs. The crushed biopsy sample means that either you curate the edge of the ulcer or you take a forceps and or a sharp end of an broken slide and you scrape rigorously or scrape the edge of the ulcer so that you get some solid tissue samples. Okay, but remember this is an ulcer which bleeds very easily, so remember not to cause much trauma to the site. Just take the crush. Other things that you can do is take a biopsy and the biopsy sample. So whenever we take a punch biopsy, we are left with a cylinder of a sample. You take the sample, you put it between two glass slides, and then you crush them. Okay, wrong arrows. Yeah. So then you crush the slides and make a smear, then stain the smear. Okay. The stains that you use, and this is a good Viva question, stains to use Donovanosis, sorry, to diagnose Donovanosis. You have the Leishman stain, GMSA stain, Delafield HNE, Wright, Pinasanol, and these there are different stains. If you just want to remember, maybe in some kind of quiz it could be asked, but for just for academic reasons. Okay, so these kind of stains are mentioned to diagnose Donovanosis. Now, there's a technique by slow GM stain in which you keep the stain overnight, and it has been reported to have near 100% yield for Donovanosis. So that's one more technique, that to stain it, leave it overnight. Other diagnostic methods are modified GM stain, also known as rapid diff. This was what it was used in Australia, and this has been found to be faster as compared to other methods. Okay, Australia, and this was significantly faster. You don't have to leave it overnight, but remember, all you have to do is find the Punt cells or Donovan bodies. Keep that in mind. Okay, let's move forward. So let's discuss a bit about Punt cells. These are the pathognomic cells. Okay, pathognomic cells. So you need to find out, you need to demonstrate Punt cells, you need to demonstrate the individual Donovan bodies inside the Punt cells. Okay. Now, we will discuss about the individual bacilli which needs to be seen. The bacilli again is pleomorphic, usually ovoid or bean shaped. The capsule of the bacilla stains pink while the organism stains bluish or purple. And because of development of bipolar inclusions, you have the safety pin appearance. So just to recapitulate, the whole cell is actually a polymorphonucleosides. And inside the cell, you see this kind of cystic spaces here. You see the cystic spaces. And inside the cystic spaces, you have the oval shaped Donovan bodies or the organism. Okay. And can you see this nucleus which is shifted to the side periphery? That is how you also find the Punt cells. And these organisms, they have this kind of bipolar inclusion bodies. And when they stain rather strongly, it gives a safety pin type appearance. So that is a pathognomic feature of Donovan bodies. So the whole cell is Punt cell, and inside the cells you have the Donovan bodies. So see, this whole is a polymorphonucleoside. Okay, the nucleus is pushed to the periphery, and inside it you have the Donovan bodies. So here itself you can see the Donovan bodies. It's of course named after Charles Donovan. Bodies are named after Charles Donovan, and these are the Donovan bodies. You see this cyst here, and inside the cystic inclusions you have the Donovan bodies, while the whole cell is known as Punt cells. So this is just another magnified image to show the same thing, Donovan bodies. This is another clearer image. This whole cell is actually Punt cells. One cell. Another name is green blood cell. If I'm not wrong, green blood cell, but that name is not used. The Punt cell is what will be mentioned. And inside that you have Donovan bodies. So, a good method to diagnose Donovanosis is actually biopsy, because you're going to eventually look for Punt cells, isn't it? Okay, and Punt cells can be seen in a biopsy specimen also. Additionally, you need to differentiate it between Donovanosis and other causes like syphilis or SCC for that matter. So, nonetheless, you're going to take a biopsy sample. So, it's better to know the biopsy features in Donovanosis. The epidermis will show ulceration. As we know, it's an ulcerative disorder with pseudoepitheliomatous hyperplasia or somewhat of a thickening, a significant thickening of epidermis, and you have acanthosis and the migration, not migration, but you could say a leakage of polymorphonuclear leukocytes from the dermis to the epidermis. The dermis will show a dense cellular infiltrate with large number of plasma cells and Punt cells, along with polymorphonuclear leukocytes. Now, whenever you're describing a biopsy, you have to go from top to bottom and mention the specific findings. So you will say that the epidermis shows ulceration with pseudoepitheliomatous hyperplasia with acanthosis, with few foci of polymorphonuclear leukocytes. The dermis shows dense pandermal cellular infiltrate composed mainly of plasma cells and Punt cells, showing Donovan bodies. Okay, so you need to demonstrate Punt cells and with a plasma cell rich infiltrate. In the hypertrophic variant, you can see elongation of retipegs. Now, rete ridges can be easily elongated in the ulcerogranulomatous lesion also, but in hypertrophic variant, this elongation is significantly more. So that is why it is mentioned as a specific characteristic, histopathological characteristic in the hypertrophic variant. Okay, so I tried my best to find a good biopsy picture of Donovanosis. I could not. All the pictures are either in black and white, very hazy, or very hazy in color format. So just to recapitulate, that you have the core, you have the dermoepidermal junction, you have a thickened pseudoepitheliomatous hyperplasia of the epidermis with ulcer hair in between, and you have the elongation of retipegs, and then you have a pandermal infiltrate which is composed of plasma cells and an eccentrically placed nuclei of Punt cells which has multiple Donovan bodies inside. Bipolar staining, safety pin appearance, Donovan bodies. Just keep that in mind. Let's move forward. Now, the organism is very difficult to culture. Okay, it's very difficult to grow in vitro. Let me change the color. Yeah, difficult to grow in vitro, and the growth of the organism uh, dates back as early as 40s, in which it was easily grown in yolk sac of chick embryos, and when the organism was grown it was named as Donovania granulomatus, after Charles Donovan. Okay, but the name subsequently changed to Calliobacterium granulomatus and now Klebsiella granulomatus. So initially it was grown in organism cell lines like the yolk sac of chick embryos. There have been attempts made to grow the organism in beef heart infusion agar, or the BHI, or BHI which is increased or enriched with chick embryo, but the growth is not that easily done. So modified chlamydia culture system was also used with human epithelial cell lines, and nowadays HeLa cell lines are used, but these are more for research purposes. It's very difficult to grow the organism in vitro, while there have been successful attempts in growing it inside the body. For example, you take the sample from the primary ulcer and inoculate other areas, so the ulcer grows there also. So that is easy. Auto inoculation is easy, but the in vitro growth of the organism is tough. Yeah, so we have discussed the diagnosis, and the mainstay of diagnosis is to demonstrate Punt cells with Donovan bodies. They can be demonstrated on a tissue smear, a crushed tissue smear, or biopsy sample. The molecular methods, see, there has been a good attempt or research in developing molecular methods, because then you need not take biopsies and everything. They need not cause any kind of additional trauma to the ulcer. So there have been attempts to formulate molecular methods using primers which target the 4E gene. I hope that's how you pronounce it, 4E gene. And 4E gene was used to create a diagnostic PCR, but the sensitivity specificity is not that great. Additionally, 16S RNA was used, and of course, these are all in institutional settings. They are not much approved for regular use. There is and developed multiplex PCR, which at the same time diagnose for Donovanosis, herpes genitalis, chancroid, and syphilis, all the genital ulcer disease together. So one sample is tested for all the four different ulcer diseases at the same time. So in the last slide, last week, we have discussed about multiplex or the triplex PCR for these three. A multiplex PCR does exist to diagnose different genital ulcer disease. But as of now, there is no FDA approved kit, so we need not worry about it. We just have to mention that primers including 4E gene and 16S RNA has been used. There is a genital multiplex PCR which diagnoses for four different causes of GODs, but there are no FDA approved kits as of now. Okay, finally, so we have discussed the clinical features, the agent, the complications, the diagnosis of Donovanosis. Let's discuss the treatment now. So initially there were multiple treatments, tar and everything was used to treat Donovanosis. They were somewhat effective. The antibiotic which was first used was streptomycin, which was found to be significantly effective, and that was in 1947. In fact, in India, before the HIV epidemic, the mainstay antibiotic to treat Donovanosis was actually streptomycin. But then subsequently, a lot of resistance started coming up, and streptomycin has its own plethora of side effects. So the search for better alternatives started. Okay. So the drug of choice is actually azithromycin. So remember that drug of choice is azithromycin. Okay, azithromycin. Azithromycin 500 milligram once a day for 1 week orally. Okay, and now remember that in Donovanosis, the treatment is given for as long as the ulcer is healed. So remember that you have to prolong the treatment as long as the ulcer is healed. Okay. Other regimen for azithromycin is 1 gram once a week for 4 to 6 weeks. Okay. So either you give 500 milligram a day, or you give 1 gram once a week for 4 to 6 weeks till the ulcer heals. Clear? Second antibiotic which has been used is gentamicin, but the problem with gentamicin is it has to be given either through intramuscular route or IV route. Okay, it's not an oral medication, and it has to be considered if there is no response to the prior antibiotics. So the first antibiotic that you will go for is azithromycin. The second might be another alternative could be gentamicin, but via an intramuscular or intravascular route. The dose is 1 milligram per kg 3 times a day till the ulcer heals. The third antibiotic is ciprofloxacin, 750 milligram twice a day till ulcer heals. Remember, ulcer has to heal. Now, all the partners which have been exposed within the last 60 days, you should give presumptive treatment, but the different literature mentions that the efficacy or the benefit of a presumptive treatment is not much, but it's better to ask the patient to ask their partners to come and seek help if any ulcer develops, and without that also they should come for counseling. So we have to go as far as 60 days before. For children who are exposed to Donovanosis, the drug of choice is azithromycin 20 mg per kg till the lesion heals. And if a child is born of a mother who has untreated Donovanosis, you have to give this antibiotic for 3 days as prophylaxis so that the infection doesn't develop in the baby. Okay, so the drug of choice is azithromycin. You have to give 500 milligram a day or 1 gram a week for 4 to 6 weeks or till the ulcer heals. The second is gentamicin, 1 mg per kg 3 times a day, but through parenteral route. If no response, so this is a good antibiotic to consider. The third is ciprofloxacin, 750 milligram twice a day till ulcer heals. and you have to treat all partners in the last 60 days. And children have to be given a prophylaxis of azithromycin 20 milligram per kg per day till healing happens. And you have to give it for 3 days. Otherwise, you have to treat if there is an active ulcer in children. Okay, so these are all the antibiotics. But now we're going to discuss the specific CDC guidelines regarding treatment of Donovanosis. So what CDC mentioned is treatment has to be continued till ulcer heals and completely re-epithelializes. So we remember that beefy red ulcer has to actually completely heal and the skin has to develop properly again. So then only you can stop the treatment. So with CDC, the preferred regimen is azithromycin 1 gram every week or 500 milligram once a day for more than 3 weeks. So minimum you have to treat for 3 weeks. You have to prolong the treatment more than 3 weeks if the ulcer has not healed yet. So give treatment till ulcer heals or 3 weeks, whichever is later. And this is the recommended drug of choice as per CDC. The other three antibiotics are alternatives, which include the first is doxycycline 100 milligram twice a day for more than 3 weeks or till ulcer heals. The second is erythromycin 500 milligram 4 times a day for more than 3 weeks or till ulcer heals. And the third is trimethoprim sulfamethoxazole or cotrimoxazole. This is 160 by 800 milligram, which is the double strength tablet. Okay, so this is Septran DS. And that has to be given 2 times a day for 3 weeks or more till ulcer heals. So, okay, so if you want to remember, the duration of treatment is 3 weeks or more till ulcer heals. The drug of choice is azithromycin 1 gram a week or 500 milligram once a day. The other alternative regimens include doxycycline 100 BD, erythromycin 500 4 times a day, or Septran DS twice a day for more than 3 weeks till the lesion heals. Consider adding another antibiotic if the response is not adequate. So we have discussed that before, that if the response is not good, consider adding another antibiotic. Now the NACO is easy. The NACO is syndromic management. You treat all genital ulcers, single or multiple, painful or painless. You treat it as genital ulcer non-herpetic. If there's any kind of burning sensation on any enlarged lymph nodes. So the kit that we use is white or blue. White is when the patient is sensitive to penicillin, there is no reaction. And if they are allergic to penicillin, you opt for the blue one. Okay, so in the white kit, injection benzathine penicillin can easily take care of Donovanosis. Azithromycin 1 gram single dose might not be effective. Remember, the regimen is 1 gram every week for 4 to 6 weeks or till lesion heals. Okay. If we opt for blue kit, doxycycline 100 milligram BD for 15 days is what is covering Donovanosis, but you might have to increase the duration to total of 21 days. Remember, you have to complete 3 weeks, so keep that in mind. This may work in a field setting when the proper diagnosis or consultation with a proper venereologist is not possible. It might work because NACO is supposed to form a syndromic management for STIs, not specific management for STIs. So remember, for specific, you have to follow the CDC guidelines, while the syndromic management is more for a field setting. Okay. So let's move forward. Just repeat with me. Kit 3, Kit 4. Kit 3 is penicillin 2.5 million units, 1.2 in each buttocks, single injection, and azithromycin 1 gram start dose. Kit 4 is blue, doxycycline 100 milligram for 2 weeks. Might be have to increase to 3 weeks with azithromycin 1 gram single dose. Now follow-up happens at 7 days. For all genital diseases, the follow-up is 7 days except syphilis, because in that you have multiple times you have to follow the patient. You might have to repeat VDRL and TPHA. For Donovanosis, it is at 7 days. You have to look at if there's complete resolution of ulcer. That is important because remember, the treatment has to continue till ulcer re-epithelializes. So this is an important point. You have to look at the ulcer whether it has healed properly or not. You have to evaluate the healing and look at the slow response. You might have to add a second antibiotic if the response is not adequate. You have to document any treatment failure in the presence of HIV or immunodeficiency. You have to document that. Any kind of antibiotic resistance or any reinfection. You have to rule out other causes of anogenital ulcers. You have to evaluate reports. For example, you have sent biopsy or other STI screening for Hep B, Hep C, VDRL for syphilis and all, VDRL and TPHA. So that was sent. So you have to look at those reports. And also you have to treat patient concerns, because this could be a stigmatizing disorder. It very closely mimics the primary chancre of syphilis. So the patient might be suffering from anxiety related to the disease. So you need to allay their fears. They might be fearful that they are spread it to their partner. So you need to counsel them and take care of those things. Now, one thing that I wanted to mention here, that if you are somehow using the syndromic management, so remember, in syndromic management, you are treating Donovanosis with syphilis, or actually you're considering the causes as could be Donovanosis or could be syphilis. So in that case, the difference is that for treating Donovanosis, you go as back as 60 days. But if you are using a syndromic management, you have to look at partners for within the previous 90 days. You have to cover syphilis also. Okay, so in syphilis, you go back as much as 90 days. For Donovanosis, you go back as much as 60 days. But if you're using the syndromic management, go back as much as 90 days. Okay, that's one extra point. In pregnancy, the disease might have a more aggressive course. The treatment is either erythromycin base. Remember, erythromycin base only. You do not use normal erythromycin or erythromycin mesylate. It has hepatotoxicity. So you have to use erythromycin base, the dose remains same, or you may use azithromycin. Doxycycline is not to be used. In neonates, it can present as ear infections and all. You have to make sure that you cleanse the neonate properly. If the baby is born of a mother who has untreated Donovanosis, you have to carefully clean. And they should receive an antibiotic prophylaxis, which is azithromycin 20 mg per kg for 3 days as prophylaxis. If the baby has active Donovanosis, you have to give till the ulcer heals. Okay, in neonates. Okay, so with that, we have completed our discussion on Donovanosis. For further reading, frankly, you should focus more on the CDC guidelines and NACO guidelines. I have condensed at least 3 textbooks in this video. I've condensed at least 6 to 8 individual articles in this video. So everything you need to know about Donovanosis is in this video. So if you just go through it again and again, you won't have to read Donovanosis ever again, and it's easier to understand Donovanosis with this video. Okay, so with that, we finish another series. We finish another genital ulcer disease, Donovanosis this time. If there are any comments, any doubts, any suggestions, I have received quite a few suggestions after the last video, and people have found it quite engaging and informative. And thank you for continuously looking for ways to improve this presentation, and thank you for continuously viewing my videos. The video on pathomechanism of psoriasis has recently crossed 2000 views, so that's something to be thankful for, and I am eternally grateful. So without further taking your time, if you have any doubt, suggestions, mention them in the comments, or you may email me directly. Till then, adios, bye bye, enjoy your weekend, tada, good night.